Now, the month of March marks Endometriosis, I got it right, Awareness Month, wherein we try to spread awareness around the condition which affects roughly 1 in 10 Irish women.
Joining us now is a great friend of the show, Jennifer Rock, who is going to be sharing her experience with endo alongside consultant obstetrician and gynaecologist Dr. Niamh Daly. Thank you both so much for being here. And Jen, this is something that you have been going through for a very long time, and you come in here every week with a smile on your face, regardless of what has been going on. Because Niamh, can we talk about, first of all, what exactly is endometriosis and what can it do to a person?
So endometriosis is, as you know, a common condition, and 1 in 10 at least that we know of, women have it. And it's a chronic inflammatory condition characterised by tissue like the lining of the womb, which is called endometrium, that is outside the womb in the wrong place. And that can be in the pelvis, tubes, ovaries, bowel, bladder. It can spread into the abdomen, and in very rare cases it can be outside the abdomen. It can go to lungs, brain, and there's even been reports of it occurring in the heart. So it's a really chronic inflammatory condition, and it's really common and can really impact women's quality of life.
Painful?
Yes. So the symptoms of endometriosis are very different from woman to woman, but typically you would hear about women having painful periods to start with. It can turn into pain before the periods, pain after the periods become more prolonged, more severe over time. You might hear women say, I came off the pill or came off my contraception and then the pain started. You might have bowel symptoms, so difficulty passing a bowel motion, difficulty passing urine, pain with sexual intercourse or pain with orgasm. And then women with endometriosis sometimes have difficulty conceiving. You would see it in about 50% of women trying to conceive and having difficulty. So it presents in very different ways for different patients.
And we're hearing about it a lot now because of the difficulty people are having conceiving and finding out they have endo. Jen, what was life like for you, yourself, your period, your womb? What was it like?
Yes, I suppose similar to what Niamh said, I would have had a lot of heavy periods as a teenager and didn't really think much of it. I suppose because I had my son Matthew, who's now 21, at age 18, it did bring me into the system of gynecological care perhaps slightly sooner. So I was diagnosed with endometriosis in my early 20s, which I know I'm fortunate because, as you say, I suppose through various different contacts would realise people often aren't diagnosed till later, because my understanding is you have to have a version of surgery or a form of surgery to be able to diagnose it. But ultimately, when I was told it in my early 20s, I thought that was it. I thought it was treated. I didn't really realise that this was like a maintenance programme thereafter. So then it would have resulted in a couple of years I would have had after the surgery. I would have felt an awful lot better. The symptoms were a lot less. So my symptoms then would have returned. So for me, it would have been really heavy bleeding to the point of flooding, debilitating your day to day, where you're kind of consciously and always checking around you. And it's just like it's really psychologically wearing. There's no doubt about it. And then hugely emotional as well, because you're trying to figure it out. For me, I suppose there was a complexity that it wasn't just endometriosis. So I then had fibroids and cysts as well. So I can't pinpoint what exactly was endometriosis versus cysts and fibroids within the womb, but I would have resulted in like a couple of ambulance trips into different hospitals at different stages, emergency surgeries, or just like fainting, collapsing, unfortunately becoming not the norm, but happening more frequently than what you would want to accept as your norm. So then I suppose rewind to the last couple of years, where I suppose I was fortunate enough to come across Dr. Niamh, was that interesting. I actually got diagnosed with female pattern baldness because of my anemia due to my womb. And so that's when I was brought into this beautiful lady's care. And I suppose for me, what Dr. Niamh did and what I'd always encourage people to do is become an advocate for yourself, where I didn't perhaps many years ago understand, wasn't as well read, didn't realise how common it was, didn't know the checklist to think, well, I am constipated, I am suffering with an awful lot of what Niamh said, so should I be exploring more than just accepting this as my every single month norm? Because it shouldn't be.
And were you not getting this treatment before you met Niamh? I mean, when this happened when you're 30, you're talking about ambulance trips and severe pain, fainting. I mean, what were the doctors or people you're saying?
I wasn't under the care of one particular doctor until my early 30s. So I think what was happening was I wasn't noticing that there was a pattern, and I was going to various different hospitals trying to understand why was I having constipation, having colonoscopies, things were fine. But as Dr. Niamh just said, the endometriosis element is outside of the womb, and it's outside of the colon or whatever organ it might be. So anything that would come back, it would come back that organ was fine. So it was almost, it is hard for patients to dot it together. So yes, to answer your question, I think for me the endometriosis is really only a topic of conversation now. And then I suppose where I've had a slightly different journey and completely separate to endometriosis, I had a hysterectomy last year because of all the other womb realities. And now I'm going to be forever your patient for endometriosis.
And I love it.
But it's the fibroids and the cysts and the endo. It was a perfect storm here for Jennifer, really, Niamh, wasn't it?
Yeah, I mean, I think the difficulty with endometriosis is there's always talk about a delay to diagnosis. So it can take 7 to 10 years on average for women to get diagnosed. And the reason for that is that typically you need a laparoscopy to make the definitive diagnosis. You could have symptoms, but it might be suggestive of IBS, or it might be suggestive of something else. The symptoms aren't necessarily specific to endometriosis. Or you might see one doctor with one symptom and another doctor with another symptom, and people might not piece it together like Jen had. And so we're trying to improve that for women with endometriosis, to centralised care for women with endo, and to
but to get a laparoscopy, is that is there a waiting time? I'm assuming public and private. There we go, right?
So there is a waiting list, yeah, and that's the reality. But the good thing about centralising care is we're able to now gather metrics and know how many people are waiting, how long they're waiting, and bring that back to the government. There's a body called the National Women Infants Health Programme who have worked really hard with the women advocating for themselves, endometriosis women in Ireland, who have worked hard to try and build this. And there's still a lot of work to do, but we're all working really hard to try and improve things for women.
Jennifer, you mentioned there you had a hysterectomy. Mm-hmm. Is that what is needed in this situation, or why was that?
So I'll answer this for you. So typically endometriosis, if you need treatment, there's an array of treatments depending on your fertility choices, your preferences, whether you're fit for surgery, whether you want surgery. Ideally, it would be a laparoscopy, which is a keyhole surgery to look inside the womb, look at the outside of your tubes, ovaries, womb, bladder, bowel, because a colonoscopy on the inside of the bowel won't detect endometriosis on the outside of the bowel. So you're having a test and being told it's normal, and that's not the wrong thing, but it's not the right test for that particular disease. So a laparoscopy is the golden standard for diagnosis of endometriosis, and the treatment is typically excision, so removing any disease that you can see. And that's a discussion depending with the patient on fertility desires, what that is. Hysterectomy actually typically isn't a treatment for endometriosis. And it would be a last resort for endometriosis's cousin adenomyosis for sure, because it removes the cause for pain. But for endometriosis, it can happen on outside the womb. So if Jen's heavy bleeding was caused by just endometriosis and she had pain, for example, doing the hysterectomy wouldn't have particularly solved her issue.
But there were so many other things that
she'd so much going on
with you, with the fibroids, with the cysts. When you got the news that you were to have a hysterectomy, a woman in her 30s, and you had to be put into a medically induced menopause, which is what happened to you. Mm-hmm. How were you?
Yeah, even talking about it now can be quite emotional, to be honest. So it was definitely a struggle, there's no doubt about it. You were my absolute champion, though. So when Dr. Niamh said it to me originally, I was like, for me, there's an emotional connection with the womb and the femininity, and did I want to remove it? And then obviously conversations at home as to whether we wanted to continue on with the family. So there's a lot that comes within it. But yeah, I was put into medically induced menopause so that the fibroid, which was the main reason that I had the hysterectomy, would kind of contain its size and then try and limit the blood as much as was possible. But to be honest, Maren, without being too graphic, I bled for 10 months straight. I bled through my wedding dress. I had to go upstairs and clean it. Like, of all the years to have had this, and then to be trying to wear white all year, but I didn't give up. I was adamant that I'd be that quintessential bride. So look, it's difficult, and there's so many women that are going through similar. So for me, it's about ensuring that we advocate for ourselves, check what's our norm, decide for ourselves if this is what we want to be our norm, and then seek counsel with medics to ensure that we say this isn't okay, this isn't the life I want to lead, I don't want to be bleeding this much, I don't want to be anemic, and then try to jigsaw puzzle all the answers together to get the best conclusion for you, and then talk about it to people to normalise it. I would say my son knows more about the female body than most men, or women even twice his age, because we talk about everything and anything that comes with it. Whether he loves it or not, I'll let you know in another 10 years.
Matthew,
but it's normalising.
How that has to happen in order for people to be able to have that conversation. There has to be an open conversation about periods, and remove the stigma, be able to talk about periods with women and men alike, and be able to talk about it at the workplace, and be able to talk about it with your friends. Because Jen, you said something to me about knowing what your norm was, and you just thought and this is very much the theme of when I see patients after they wake up after their surgery, and I tell them you have endometriosis, and I feel really bad telling them that, but actually they're always relieved, and the first thing 99% of them say is, I'm just so glad it's not in my head. I really thought it was all in my head. So I think that it's really important to have those conversations, because one woman's norm is not the other woman's norm. And so painful periods, difficulty going to the toilet, pain with intercourse, pain with orgasm, all of those symptoms aren't normal, and patients need to know. So people like Jen, being vocal about it helps that.
Good on you, because we see all the time here with a smile on your face, you think that there's nothing wrong, and you're going through this is incredible. How are you now?
Yeah, feeling an awful lot better. The medical-induced menopause was probably, I would say, for me, trickier to manage, with the plummet of emotions and like the night flushes and hot sweats and anxiety and pieces I wouldn't associate with myself. That was definitely trickier. But healing-wise, I'm back to the gym now, a couple of weeks. I'm able to get myself back up and at it. So just delighted to have the opportunity to speak about it, because so many do suffer with it. So thank you.
Thank you so much for coming in, for talking about that, because I know that you have been dealing with this for so many years, and as we say, always a smile on your face. You're just blooming brilliant, and you're always advocating for other people. And Niamh, thank you for all those things that you said. If you're having any of those issues that you mentioned, those pains,
go to your GP.
Go to your GP and mention it.
Yes,
because we have to start talking about
it.
Exactly. It's been a pleasure having you both in here.
Thanks
as always. Jennifer Rock, thank you so much for coming in, and Dr. Niamh Daly, consultant obstetrician and gynaecologist. Thank you both so much for being here. Well done.
Thank you.